Muted.
Good afternoon, everyone. I'm Paul Bergantino from Lifeway Mobility. We're the host of this one-hour session today. So our company, Lifeway, services Southern New England. We provide solutions in two key areas, accessibility and safe patient transfers. So when I say accessibility, so for folks that are looking to overcome architectural obstacles, such as stairways, navigate around bathrooms, etc., we provide products such as ramps, stair lifts, wheelchair lifts, ceiling lifts, bath safety products, and other related products to help people with accessibility. Our other primary focus is safe patient transfers, to help someone move from a bed to a wheelchair, on or off a toilet, in or out of a car, up from a floor. And these are solutions that are geared towards helping caregivers and clinicians, helping them stay safe and as they're transferring their patients. So we provide these products for folks that are active, semi-active, meaning they can weight bear or partially weight bear, or the passive patient. So if we can help you in either of these areas, feel free to contact us. We offer free evaluations. So today's seminar, Improving Outcome Measures Through Safe Patient Handling and Mobility, is being presented by, this presenter not only has experienced a serious back injury herself while transferring a patient, but she's a clinician, she's a safe patient handling subject expert, and she's provided training all over the country. I'm excited to introduce Amber Perez. Amber?
Hello. Let me get my screen here. Good afternoon, everybody. I'm happy to be here today and be able to share this with you. Just a couple of housekeeping items. I will be taking questions on the screen. You can type them under the questions tab, but we'll be addressing them at the end. And we'll also open up your lines to be able to speak and ask questions at the end, but right now everybody is muted. Also, if you do have something, you can't see the screen, you can't hear something, go ahead and type it in the chat and our organizer can chat with you and try to answer that question while we're giving the presentation. So we're just going to go ahead and get started. We'll be talking about improving outcomes through safe patient handling and mobility. So the outcome measures that we can focus on with safe patient handling and mobility, we look at caregiver injuries, and we're going to be talking about musculoskeletal injuries and the direct and indirect costs of these injuries. And then we're going to be talking about patient injuries, patient falls, pressure ulcers, and other effects of immobility. We're going to begin talking about caregiver outcomes, healthcare injury costs and risks. So when we think about workers' compensation costs in the healthcare realm, whether you're working in a hospital, a big hospital system, long-term care facility, home care, all of these have a common theme, and that is the risk of patient handling injury. And unfortunately, in the past, many have seen the patient handling injury as just a cost of doing business. OSHA has since alerted to some of these injuries, and the Bureau of Labor Statistics is reporting the drastic amount of injuries that we're seeing in this realm, and they're starting to pay more attention and say that's not okay. There's just too many injuries in this setting to just brush it off as a cost of doing business. You might ask yourself, are the solutions affordable for your organization? Oftentimes you look at safe patient handling solutions and you think, wow, that costs a lot of money. Is it worth the investment? And really, what am I getting back out of that investment? So we'll talk about that. What is the actual impact of patient handling injuries on my organization? So I'm going to go into a little bit deeper about what is the total, not just financial, but efficiency and time that your staff spends when they do and don't utilize safe patient handling. And then you might ask yourself, is my staff or myself at risk of injury? And a lot of people really haven't explored this and really seen what are the actual risks that I face every day. Many of us, myself included, I'm a nurse. I spent 13 years working in the bedside and didn't really look at my daily tasks as something that was dangerous. It was something I was taught as a normal part of my job. So when I really started researching and understanding what risks I was facing, I really started to understand why the back injury I sustained was not so uncommon or should not have been unexpected. So we're going to first talk about musculoskeletal disorders, and this is really how they're categorized. When you're looking at your workers' compensation claims and injuries, we categorize them in specific ways. You'll see needle stick, slip, trip, fall, and musculoskeletal disorders are the category of injury that talks about sprains and strains. So that's when you see the back injuries, neck injuries, wrists and knees, and they're all categorized together. So according to OSHA, the musculoskeletal disorders are caused by lifting heavy loads, especially when bending or twisting, repetitive forceful movements, awkward and static positions, fast-paced work environments, and prolonged standing or sitting. When you look at that list, it's particularly telling when we learn about why there are so many injuries in healthcare, because this is in general why we sustain musculoskeletal injuries. And when you think about the tasks that are performed in healthcare, all of these speak to the tasks that we're performing when you're in a healthcare setting. So when we look at the musculoskeletal injury rates in the United States, we're looking at a chart from 2013 and 14. Healthcare and social assistance is kind of bundled together when we're looking at MSDs. But what I find particularly interesting is that except for transportation and warehousing, healthcare ranks higher than any other industry. When we look at this chart, this was put together by Biodynamic Laboratories, and they were looking at, I love the title of this, Most Dangerous Jobs in America. Many of us in healthcare, we wouldn't consider ourselves to be in one of the most dangerous jobs. You think of mining or truck driving, construction, as much more dangerous. But when we're looking at lost work time due to back injuries, working in a nursing home or hospital combined is a greater risk than any of the others. And working in a hospital is still more dangerous than construction, mining, or agriculture. That to me was very interesting because it's not something that we tend to believe is a great risk. You think of a healthcare job as a nice indoor clean job, and you're not often thinking of the great risks of injury when you're working in that setting. So what does the research say, and why are these injuries occurring? We look to the National Institute of Occupational Health and Safety, or NIOSH, and that's really the branch that does the research for OSHA. So OSHA says, what are the risks? How should we place our guidelines? And NIOSH gives them the answers. So right now for general industry, the safe lifting limit is 51 pounds. And that was based on research that they did to determine how much a person could lift before they became injured. So some of the questions that they're asking in their research are, why do these injuries continue to happen in healthcare? How is healthcare different from other industries? And this was one of the biggest questions they had to answer. Why are healthcare workers getting injured more than people working in a warehouse maybe, or people working in construction when they're also lifting heavy loads? So what are the specific ergonomic risks? So they got ergonomists involved, and they really look at how does a job fit with a person. They wanted to know how much weight can a caregiver safely lift, and they wanted to know what are your recommendations for safe practice. So I love showing these pictures because this is a picture of Dr. Maris's work from Biodynamic Laboratories, and he did this work for NIOSH, and he actually designed a tool that could measure the compression force and the shearing on a spine. And you can see in some of these pictures that they replicated common tasks in healthcare. So one person transfers, two-person transfers, boosting in bed, pivot transfers, and they followed the recommended practices for safe body mechanics. So the way that you would train somebody to lift and move a person following proper body mechanics. And they wanted to know, is that enough? And are we able to prevent injury by following these rules that we've always followed in healthcare? What he found was no, nothing was safe. When you look at each of the different tasks that he measured, every task exceeded the safe limit, and many of the tasks exceeded the maximum tolerance that a spine could take. This was very, very telling, and it helped us to understand that what we had been using as our baseline for so many years in teaching our staff and teaching our caregivers really just wasn't enough to protect them from injury. When he was measuring it, he was measuring the compression the lateral and the anterior posterior shear. So shear is, imagine the spine twisting and moving, and then compression is the weight coming straight down. So those are many of the things that he measured in his study. What we found was that when you manually lift in healthcare with our awkward static positions greater than 35 pounds, that we see microfractures on the spinal end plates. Now, if I go back, the spinal end plates are the areas where the bone is touching the disc. And these end plates are responsible for feeding the nutrition and the fluid into the disc. Now, when you have a damaged end plate, you're no longer able to give those nutrients and fluids into those discs that are needed. So what we found is that not only are these patients at risk for short-term injury, like bursting a disc or exceeding those maximum tolerance limits, having some sort of muscle strain around the spine, but we're seeing these long-term injuries. And these are caused by repetitive, forceful movements that are exceeding those limits day in and day out. So when I talk to a caregiver, I say, you know, when you work your 8 or 12-hour shifts and you've finished your week and maybe you've done 3 12-hour shifts in a row, you know how you feel on the end of that third shift? And they all go, yeah, and they nod their head a little bit, and everybody kind of reminisces back to maybe a little bit of a sore back or a sore neck or shoulder, and you think that's just how it is at the end of doing a job in healthcare because we do so much physical movement. But the reality is that that is really a result of over exceeding our limits. And when we do that, we see cumulative injuries. And the scary part about a cumulative injury is that it's not reversible. When you have a nurse that goes for 20 years and maybe they never suffer one major back injury, they might have built up so much cartilage and scar tissue on their spine that they end up with disc degeneration or they end up with long-term nerve damage. And that's really not what we want our caregivers and these people that have been so altruistic throughout their career to end up at the end of their career as a result of their job to be disabled themselves. So we really need to start looking at differently and understanding that we need to prevent the short-term injuries, but we also need to preserve our staff so we have enough employees, so we have people that are able to work in the long term. So really, what is the cost of an injury? We're going to look at the direct and indirect costs. So when we look at direct costs, they're usually measured medical, indemnity, and legal. So when I talk to an organization, sometimes they'll say, you know, we really don't have that many injuries, and we really don't spend that much money on injuries. And all they're looking at is that direct medical cost. So maybe they say, for my whole hospital for the entire year, I only had $30,000 in injuries, and that doesn't justify me investing in safe patient handling. However, we have to calculate the indirect costs as well. These are more difficult to capture, but they include the turnover rate. We know that recruiting and replacing staff is very expensive. Studies have shown that absenteeism due to unreported injuries is about 15 to 18% of unscheduled absence. Sometimes you'll have a culture in your organization where you don't encourage reporting of injuries, where staff are afraid that they may lose their job if they report an injury, so instead they call in sick. And that may be costing your organization money as well. We know that we have to staff to compensate for the loss. If we have somebody with a lost day or restricted work day, that costs money as well. And maybe it ends up being that the only staff that can replace them are now on overtime, or we're having to pay an agency, and we know how much more money that costs. Then we talk about the loss of productivity. We might have less staff on the floor. We might have untrained or inexperienced staff, maybe from the agency or floating from another unit. Or we might have people who have unreported injuries that aren't able to fully perform at their normal capacity. The quality of care, the morale, the cost of time for the administration to process these claims, to file the claims, to check in the patients in occupational health. All of these things are things that you really don't think about. You think about the direct medical costs. So I want you to start thinking about all of those indirect costs that I just started talking about. So we're going to go through a case study, and this is a United States hospital. It's a community-based hospital, about 200 beds. They have some patient handling and some biomechanics training. They have a few pieces of equipment. They have no ceiling lifts. They have a culture of team lift. Everybody helps everybody, rather than using proper patient handling equipment and techniques. And what I'm going to share is actual data from a hospital for this demonstration purpose. So at this facility, we had 2012, 2013, and 2014. The first column talks about, or the first line is patient handling injuries, then days away from work and restricted days. So you can't just look at the number of patient handling injuries and use that as a measure. In risk management, we never use that as a measure for how well or how poorly your organization is doing with patient handling injuries, and this is why. If you look down at the second line, days away from work, in 2012, you had 51 injuries. In 2013, there were 46 injuries. So only 5 less injuries. However, days away from work are dramatically different. You had 527 days away from work with only those 51 injuries, and just 177 with those 46 injuries. When you go down to restricted days, now this is light duty. The doctor says you're injured, you cannot lift, but you can go to work and assist with answering phones. We had dramatically more restricted days in 2012 than we did in 2013. And then when you look at 13 to 14, you had less injuries reported in 2014, but dramatically more restricted work days than you did in 2013. So why is that, you might be asking yourself. So this lets us know the severity of injury. And really what we want to address when we're addressing a patient handling program is how do we reduce the severity of injuries? And how do we improve our patient handling injury reporting? That injury number can be triple, and it still could have a lower cost associated. Because we want our staff to be reporting injuries early so that they can be preventative, so that we can address the problem right away and say, here's a solution so you don't get hurt again, so that you don't get further injured. But when we discourage reporting, they're likely to not report to us until their injury is so severe that they cannot work. And when that happens, that injury is much more costly to the organization. So we have to be able to measure the total impact. And the impact isn't just that number of injuries, but it's the days away from work and the light duty days. So when you go down to the bottom line, we talk about the total incurred medical costs. And these are, if you remember back to the slide previously, these are the direct medical costs. So this might be what your organization sees as the total picture of their problem. In 2014, we spent $112,000 on patient handling injuries. And while that seems like a lot of money, that's actually a low average when you compare facilities of that like size. But when we talk about those indirect costs that were not calculated on that slide before, we know, based on several studies that were done, that for every $1 of direct costs, there's $3 to $10 of indirect costs. So that's how we calculate that hard to capture number when we're looking at all those other things that are impacted when somebody is hurt. So below on the bullets are some of the studies that I used to gather this number. So if we're conservative and we say 4 times, and I always like to use 4 times, even though some people will say let's multiply it by 10, which is the greatest number that we've seen, but we'll be conservative and give the benefit of the doubt for this organization. So if their direct costs are $112,000, then we can safely estimate that all of those indirect costs are around $449. I like the analogy of the iceberg, because really popping above the surface in that picture there, that represents what your organization tends to see. And they think about, when I have a patient handling injury, it might cost me $1. But below the surface could be $3 to $10 in unexpected indirect costs that they're not accounting for, that really do make a big difference in the organization. So when we're looking at the sample hospital for 2014, that $112 is actually about $561,000 in the impact of direct and indirect costs for the organization. What about those days away from work and restricted days? Studies also tell us that it costs about $1,000 a day every time somebody has a paid day away from work, between the cost of their medical care and paying them, staffing, and then the cost of the people that have to restaff that position. So when we count those costs in as well, we have to think about the 307 days away from work and the 575.5 restricted days. And we know that there's another $422,000 in costs associated with those injuries that were reported. So we have our direct and indirect costs, we have our light and lost days, and our total impact to the organization on 30 injuries is almost $1 million. And really, that's the number that we have to be able to show to the organization to help them understand that 30 injuries at only $112,000 is not the total cost that you're paying when you don't have safe patient handling. And really, can your organization afford not to implement safe patient handling? Can they afford to be dumping $1 million a year out the door because there is no equipment available for the staff? So that's really the calculation I want you to think about, and to think about asking your organization, how do we calculate our patient handling injuries, and are we really looking at the total impact? But there's also a cost of manual handling. We have to think of the cost of inefficient work, because the number one reason staff say they don't use patient handling equipment when it's available is that it takes too much time. Some of you might be nodding your head out there, and maybe you believe that yourself, and I used to believe that. I thought, wow, you know, this guy needs me to come and transfer him out of bed, and if I go get the mechanical sit to stand, I have to walk down the hall, I have to find the sling, it just takes too much time, so they don't do it. Or maybe administration believes staff won't do it, it'll take them too much time, we want them to be fast. So when I was working with my hospital organization, I did a little study, and what I did is look at some common tasks that were occurring on our floor. And I went to one of our hospitals that was not very advanced in patient handling. And then I also went to one of our hospitals that was the pilot for safe patient handling. So one of them used equipment on a regular basis, and the other one did not. And what I found was pretty interesting, that when a task was done manually, you can look at the amount of time in the first column, and you can look at the number of employees in the second column. And what we have to remember is that number multiplies, because if it takes 5 minutes to boost a large patient with employees, or 10 minutes to boost a large patient with equipment, is it really just 5 or 10 minutes? And you look at the fact that it took 4 to boost that patient in 5 minutes, or it took 1 employee 10 minutes. So the total time for the manual move is actually 20 minutes. And that's time that we pay. That's time that those employees could be doing something else. And when we really want to think about efficiency and enabling our staff to perform as much as they can in as little time as possible, which is the push for everybody, does it make sense not to have them use equipment? So I looked at the total time for manual tasks versus lift equipment. Oh, sorry. And then I looked at it again, and I said, what is the cost? Because not just the time, but what is that cost of that time? And excuse the last column there. I meant to take that out. I did a presentation in Europe, and they wanted the euros on there as well. But when you look at that 5 minutes and 4 employees, and we look at the average cost of a fully benefited employee, and then we multiply it, you can see that the total cost without equipment was around $258 in staffing costs, or euros. We also looked at the total cost when you did use lift equipment. And when you use the equipment, we had a dramatic savings in our staffing costs. One of the interesting things, too, was looking at the total time. And this one task in particular, when you look at limb holding for a laboring patient. And I was asking the staff, what do you traditionally do? And they said, well, our bed does have stirrups, but none of the patients like to use them, and a lot of the doctors don't like to use them because we would prefer to hyperextend the woman's legs while she's pushing. So the dad will typically hold one of the legs, and a nurse or a nursing assistant will hold the other one. Can you imagine how much time we're spending paying somebody to hold a woman's leg when we do have technology and limb straps and ceiling lifts that can hold that leg for her and allow her to move it into the position that she wants to for labor? So those were some of the things that I found to be such a dramatic difference in a cost savings if we really were smart about thinking about where we put the equipment. So talking about these tasks, we looked at a 300-bed facility, and it's very interesting, and your mind's probably turning a little bit about, okay, well, if they're pulling up in bed 800 times a day, and we know how much more time it takes when you do it manually, what is that total cost to the organization with all of these different tasks? Turning 700 times a day, stand assist 300 times a day. We know 2,440 tasks are happening in a 24-hour period. And when we're relying on each other to do this, not only are we being inefficient and wasting that staffing time, but we are also increasing the risk of injury by that many more. Now we're going to talk about the patient side of things, because we are all in healthcare to help the patients. And as much as healthcare workers don't want to think about themselves, it's so important to think about yourselves. It's so important to think about your staff. But in the end, we're doing this for the patient. And the reason that we're in healthcare is for the patient. So we definitely want to make sure that you make that connection as well. So we know that when it's difficult to move a patient, the activity is often not performed. So we ask ourselves, are we contributing to the problems of immobility? I think back to an actual patient experience that I had when we had quite a large patient. It was a bariatric patient. He was weighing around 600 pounds, and we didn't have the right lift equipment to lift him. So even though the physician orders instructed us to get the patient up out of bed twice a day, because the physician knew that this patient could not be immobile or he would have negative outcomes, what choice did we have? And oftentimes, when it's not that dramatic of a situation, we still don't have the resources to be able to perform a lot of the activities. So staff will find an easy way out. Rather than standing and transferring a patient to a toilet or commode when it's very difficult, we might offer a bedpan. The patient is still able to use the restroom or be cleaned or changed or whatever it is, but is that benefiting the patient, and is that the way that we should be serving our patient? We know that with healthcare reform that there are many more requirements on our healthcare organizations, and that we have to be very cognizant of the outcomes that we are delivering. We are being required to report those and to deliver a much healthier patient and a much higher quality of care. So what we know is that there are immobility-related negative patient outcomes. When I talk about assisted falls, that is any fall that occurs when a person is present, a caregiver or a staff member. Some people call it witnessed falls. So this might occur with a patient who maybe previously had more strength and we believe they could walk to the bathroom, and during that walk to the bathroom they fell. Or maybe a patient who couldn't wait any longer to get out of bed, and as we were coming they stood up and we saw them fall. But mostly it's when we are assisting a patient to a bathroom or assisting a patient up out of bed and then they fall. Pressure ulcers, we all know what those are. And then other effects of immobility. And those include hospital-acquired deep vein thrombosis, pneumonia, catheter-acquired urinary tract infection. We'll see an increased length of stay, hospital-acquired debility, I already said increased length of stay, and then also a poor discharge disposition. And what I mean by that is that when a patient is left immobile in a hospital or a long-term care setting, they tend to debilitate and either don't have the opportunity to discharge from that long-term care or that rehab as previously planned, and then they end up in a long-term care permanent patient, or a patient that previously was expected to go home after hospitalization may not have that option anymore. There's an actual diagnosis called hospital-acquired debility, and that means that they became so debilitated and so deconditioned while in the hospital that they are no longer able to take care of themselves and move and transfer as they did before. That diagnosis, to me, puts up a lot of red flags. We shouldn't be having patients that are worse off because of the care we gave them. But oftentimes this happens because we just don't have the resources to get patients up as we should. And we know that the best thing we can do for patients is to get them up for all meals, to get them up to the bathroom, to get them up and move as much as possible. But reality in a hospital and a long-term care setting is that if you don't have the equipment and the resources to do this, we find ways of letting the patient stay in bed. So when you look at the statistics, in the hospital and long-term care settings, falls continue to be the #1 adverse event. About 3 to 20% of inpatients fall at least once during their inpatient stay. And of those, 30 to 51% result in an injury. We know that with the new healthcare reform, Medicare and Medicaid will not pay a hospital for a patient injury that occurred as a result of a fall. So if you have a patient who falls while in the hospital or in long-term care and they break their hip, the hospital is responsible to pay for that surgery, to pay for any of the care and extended length of stay that occurs as a result of the fall. Of course, it's also completely irresponsible for us to be allowing a patient to get hurt while that's in our care as well. But the financial impact is definitely something that we need to consider as well. Based on 2010 dollars, one fall without serious injury costs $3,500 to a hospital. A patient with 2 falls without serious injury, $1,605, or $500. This is not serious injury. These are not hip replacements, or hip fractures or head injuries. Falls with serious injuries are definitely the costliest, and we know that. And they cost hospitals around $27,000. This impact of patient injuries is a huge financial impact on the hospital. We know that according to the prevention and treatment of pressure ulcers, that they recommend that we do everything we can to prevent pressure ulcers. We know that this is a great cost to the hospital and that it increased the hospital costs significantly. It is estimated that the care will cost around $11 billion annually. We also know that with healthcare reform, this is another one of those never events that Medicare and Medicaid will not pay for the cost of the care associated with the development of stage 3 or 4 pressure ulcer that developed while in the care of a hospital or a healthcare organization. So if we are unable to frequently turn and reposition and care for our patient the way that we need to prevent those pressure ulcers, and they develop one in our care, we have to pay for that in the organization. That is so costly to the organization that it's something that they have to consider as a total impact to not having patient handling options. We look at some of the other effects of immobility on the patient. We're not going to break down the cost of each of these, but you know that each of these do impact the hospital as well, and the patient, the length of stay, and their overall outcome. If the patient remains immobile, we see pneumonia, we see pulmonary embolisms, constipation, gastrointestinal ileus, urinary tract infections and kidney stones, deconditioning, bone demineralization, joint contractures, pressure ulcers. A lot of cardiovascular effects. We'll see patients with hypervolemia or orthostatic hypotension, and that increases their risk for falls as well. We see deep vein thrombosis occur also. We see depression occur, and more recently there have been a lot of research that has come out about delirium and the effects of immobility. And patients in the ICU will be more likely to suffer from delirium if they are not being mobilized and exercised. And delirium occurs as a result of long-term sedation where the patient is not able to fall into a natural REM cycle. And so we've recently released all of these new strategies and therapies and ways of changing the medications and changing the way that we treat the patient in the ICU. And one of the most important interventions in their bundle is, it's an ABCDE bundle, and the E is early mobility. And what they find is when you move and mobilize these ICU patients, it helps their body to naturally tire and to be able to fall into that REM cycle, which is so important cognitively for them. They have found that delirium is a primary indicator for death, not a contributing indicator for death. So that means people can die from delirium. And if they don't die, we see permanent cognitive changes on a patient's MRI. So this is a dramatic effect that early mobility can play in the life of a patient, but we must have the resources to be able to do this. I don't know how many of you are from that world, from the ICU setting, but also in the long-term care and long-term acute care settings. When you have patients that are very ill on a ventilator or multiple devices and machines, it's very difficult to perform movement and transfer, even if they don't weigh a lot, because you have many things to consider, and you have to ultimately consider the safety of that patient while you're moving them. So when we look at everything we talked about so far, we have the staff injuries, and in this calculation with MedPAR data, they came up with about 977,000 as an average per year, which was very close to our case study of $980,000. Falls cost the hospital about $367,000. Pressure ulcers, over $1 million. Pulmonary complication, including ventilator-acquired pneumonia, over $2 million. Deep vein thrombosis and blood clots, 500,000, and we don't even know the impact of deconditioning. That's something that we don't have solid numbers around yet. What is the total cost and impact to an organization? So even without that, we know that in 1 year, if all of these things come into play, that we could be talking about over $5 million that a 300-bed hospital has to absorb in the effects of immobility. And over 5 years, that's $27 million. So what can we do? Well, oh no, we're not there yet. I'm sorry. Recommendations. So when we look at the regulatory and professional recommendations, we want to say, what do these organizations tell us? When we look at NIOSH, as we talked about before, they recommend that for the general industry worker, 51 pounds is a safe lifting limit. For healthcare industry workers, caregivers should not exceed lifting 35 pounds without mechanical assistance. Now, why is that? That healthcare has a lower weight recommendation than the general industry, and the reason is that we cannot perform our lifts and movements with proper body mechanics. We know that in general industry, when you think about a worker picking up a box of paper, that box has handles or may not have handles, but you can grasp it in an even position. The weight of the box is evenly distributed. It's a common size. You can bend at your hips. You can lift with your legs, and you can move that. When we think about healthcare, it doesn't work that way. Our patient's weight is not evenly distributed. We would look awfully strange if our head and our midsection and our legs and our feet all weighed the same. So we are unevenly distributed human beings, as we should be. And moving a patient means that you tend to have to reach over a bed or twist or move or stand in an upward position. So because of that, we know that we can't safely even lift 51 pounds because we're putting our bodies in positions that increase our risk for injury. So they found that 35 pounds was the limit. And what they recommend is either mechanical assistance or team assistance. So they put out this algorithm, and the algorithm to me, or anybody who works in a healthcare setting, might find this a little bit ridiculous. So when you think about the team lift recommendations, if you have a patient that is, let's just jump all the way to the bottom, 210 pounds, that's really not that heavy of a patient in the United States, unfortunately. That's pretty average. 6 people would need to assist with that 210-pound person in order to safely help move them. I know, and you know, that's not happening in our hospitals, in our long-term care and at home. There may not be 6 people on staff, and even if there were, we've gotten into an understanding in healthcare that lifting heavy loads is part of our job. I would say that if you had a 210-pound person, probably the most normal reaction would be to have 2 people lift them, and we know that that exceeds their limits. So every day, even with people attempting to be safe, realistically, they're exceeding the capacity of what their body can do. When we look at the NPUAP, and that is the National Pressure Ulcer Advisory Panel, and we want to say, what are their recommendations for preventing pressure ulcers? They recommend using manual handling aids to reduce friction and shear, so we don't want to drag our patient's skin. they specifically say lift, don't drag while repositioning. When you go to any healthcare facility in the United States that does not implement safe patient handling, the basic traditional technique for boosting a patient is to grab a draw sheet or a Chuck's pad on either side of the patient, say 1, 2, 3, and we drag them up the bed. And we know that that's not safe for the caregiver. We know that that's probably exceeding their safe lifting limit. But now we also know it's causing an increased risk of pressure ulcers on that patient. One of the most common pressure ulcer places on a patient are their coccyx or sacrum. And that is the pressure point that is being dragged up the bed every time we boost that patient. Boosting a patient in bed is one of the most common tasks that happens throughout the day. And if we're shearing that patient's skin over and over, even if we're turning them, even if we're doing everything else we should, we're increasing the likelihood that they'll develop that pressure ulcer. They recommend that you use a split leg sling and mechanical lift when available to transfer an individual into a wheelchair or bedside chair. And they also recommend that you increase activity as rapidly as tolerate, that individuals on bed rest should progress to sitting and ambulation as rapidly as they can tolerate. SAMA is a patient handling and movement assessment. And this was a white paper published in 2010 from our friends at the VA who have really pioneered a lot of the safe patient handling research. And they recommended equipment quantities. And this is interesting to know, and I'd be happy to share this with anybody that's interested. When you want to know how much equipment do I actually need in order to prevent injuries, and this is an idea of what they recommend, from ceiling-mounted lifts to mobile lifts, sit-to-stands, and then how many slings do I need. And what they found in their assessment was really they understand that you can't buy everything. You can't have a lift, a mobile lift outside of every room. We have storage concerns, but really how many need to effectively be able to take care of your patient. So our solutions to all of these problems that we presented today are really thinking about safe patient handling and mobility, or SPHM. So what I'm going to do is go through some of these based on the issue. So at the top, you'll see data-driven recommendations. So if you're looking at your patient handling injuries in your organization, and we're going back to the beginning of the presentation where we talked about workers' comp injuries, and you found that boosting in bed or pulling patients up in bed or repositioning, however your hospital categorizes it, is the #1 injury for patient handling in your organization, that's where you need to start. And I always recommend being prescriptive about your approach and understanding that when you help address a problem, you're going to see a result, and therefore you'll get a lot more support to continue to do this in your organization. So I have good, better, and best. So we do have some solutions. If we look at good, we would have a device that helps a caregiver stand in a more ergonomic position, and what you can't see under that patient's head is that they have a friction reducing sheet. So these two caregivers are going to be able to help pull this patient up to the top of the bed and stand in a better position and reduce the friction while doing that. What is better, and always better, is if the patient can be involved. So what we're looking at under better, and there are many types of different devices like this, but anything that's friction reducing. So if the patient could bridge their body and push themselves up the bed, the caregiver is not at risk for injury, and the patient is participating. And that patient participation is a form of early mobility. It's getting them exercising and moving and participating and preventing some of that deconditioning. Although the best recommendation, we think, is to, and this is for a dependent patient that you would not be able to ask to move, is to be able to, just as the NPUAP suggested, lift and set them down. So we don't want to drag them up in the bed. We want to lift their body, move their body, and set them down. And on this next slide, I have kind of a picture of that. With a mobile lift or a ceiling lift, you'd be able to completely raise the patient up, clear them from the bed, either move the lift or the ceiling lift and set them back down. Really, that is going to be the best way to prevent that patient from injury and all of the caregivers from injury as well. So when we look at lateral transfers, and lateral transfers are any time you move from bed to bed laterally across two surfaces. Maybe it's stretcher to diagnostic table. In the OR, it's stretcher to OR table. So in some places, this happens all the time, all day long, in your emergency department, with your transport team, and in your diagnostic areas. What we see is that if you perform this traditionally, you have people on either side grabbing the sheet and pushing and pulling. Some of the risk with this is that we are extending our body and we're pulling with our arms completely extended. And that increases the compression on the spine by 10 times. So this is one of the more dangerous things that you can perform without some equipment. But we have some good equipment. We know that we have friction-reducing slide sheets, and you'll see that under good. These are an option that are disposable, and you can put them under a patient who's lying dependent. You don't have to even turn the patient to get it under the patient. It reduces the friction, so when you're pushing and pulling them across the surfaces, it's not, the lower friction helps them to be able to slip across the surface rather than being pulled against the friction. On the better side, you'll see a slide board, or a roll board, a roll board. Traditionally, people have used slide boards in the past, which are those white, long boards that are still in many of the hospitals. And while they're okay, they were originally designed to be able to cover that gap between the beds. Anymore, you don't often see a gap because you have a zero gap bed or a zero gap stretcher where the handle goes under and tucks underneath. But even if there is a gap, a roll board is actually a better solution. It used to be the white slide boards were highly slippery. They were a great friction reducing option. But then they found that those really slick boards were often creating static electricity. And that's not good in the healthcare setting. We don't want to have static electricity around all of our oxygen. So they made the boards a little bit different, and they have a little bit of texture on them, which reduces some of that frictionless property that they had before. So it's still a good option, and I would recommend using it rather than nothing. But the roll board actually has a piece of friction-reducing material around it, and it rolls around the board as the patient is moved. So it really assists in helping push the patient from one bed to another. And then again, the best solution if you have a completely dependent patient to reduce the risk of patient injury, to reduce the risk of staff injury, is using a lift and transferring the patient. So that same safe handling sheet that you could use for boosting, you can also use for transferring, and you can also use for turning. So I always recommend if you're in a highly dependent situation, you have an ICU or you're working with bariatric patients in a hospice setting, a long-term acute care setting, or a long-term dependent patient, that you consider using a safe handling sheet because it really does so much. You can transfer out of bed, up in bed, and help turn that patient every 2 hours. So then we'll talk about transferring out of bed. And this is something that also happens quite often, and depending on your setting, might be the most common transfer that you see. We look at good, better, and best again, and I'll show some of those pictures a little bit clearer. In the bottom picture, you have the caregiver who is using the device with the handles so that she can stand in a more proper ergonomic position. Without that device, she may be reaching under the patient's arms, and that makes her have to bend her back forward and move her center of gravity, where she is putting herself at a bigger risk of injury. The patient may be more prone to grab around her neck and do something that could hurt her. He's standing on an anti-slip pad, and that's just for his safety, so that as she's standing him, he is able to keep his footing. And that's really for a patient who has the ability to stand and just needs a little bit of help. And then we also see on the top what is called a non-powered stand aid. That particular one is called the return. And this helps a patient who has the ability to bear weight but needs some assistance in transferring and moving. One of my favorite departments to put this in is a neuro department, or using it with patients that have Parkinson's or multiple sclerosis. Sometimes these patients still have the ability to stand and walk, but they don't have the speed. And oftentimes at night or during the day, the patient might need to use the restroom or get up somewhere urgently. And this really helps them to still participate, and they are helping to pull themselves to stand. They're still bearing weight during the activity. But this device has 6 wheels on it altogether. It can pivot on a circle, and it's really convenient for small areas where you have to stand and pivot somebody from a bed to a wheelchair or get them onto that toilet. And then on the left-hand side of the screen, you'll see the mechanical sit-to-stand. Now, if you have a patient who is able to bear weight but really is not able to help stand and really cannot activate to assist in the movement, we don't want the caregiver to be injured. We don't want the caregiver to be pulled down or for the patient to be injured if the caregiver is unable to support his weight. So the mechanical sit-to-stand really offers you the option to help bring that patient to an upright position to transfer them. Unlike the total lift, you're still getting some patient benefit out of this. With the total mobile lift, while it's very necessary for some completely dependent patients, if this patient has the permission to bear weight on their legs and the ability to participate in this activity, they're getting some good benefits out of it. They're still bearing weight on their legs. We're preventing bone demineralization. It helps prevent DVTs. They're standing upright, which helps challenge their cardiovascular system and is good for preventing some of that orthostatic hypotension that we see in our long-term immobile patients. And then we talk about walking or ambulation. And again, we talk about the different kinds of patients and the different options available to them. So on the left-hand side, you'll see a gait belt, and this is a little bit more advanced of a gait belt than a traditional gait belt. There are several handles on the side and on the back, and it really helps the caregiver to stand next to the patient and hold on while they're transferring. So this would be a patient who we know they have the ability to walk, but sometimes they have moments of instability. Sometimes they need some guidance, and it's great to be able to offer that to them and keep them safe while they're transferring or walking to the bathroom. In the middle, you'll see a specialty walker. And this specialty walker has all sorts of accessories. It can be with or without the accessories, but it allows a patient who maybe has an IV, an oxygen tank, a wound vac, a ventilator, whatever it is. All of their devices can be put onto the walker, and then you'll see behind the patient there are safety seats. So the patient can bear weight through their upper extremities, and they can do their walking activity, their therapy with the physical or occupational therapy staff. But if they become too tired, rather than having another staff member follow behind them with a wheelchair, they can simply take a break. Or if they have a little bit of instability, you can have those seats ready so that if they sit down, they sit on the seats rather than falling to the ground. So it's a safe way to push that patient who has ambulation ability but maybe has some risks. Rather than not walking them or leaving them in bed, we're able to really maximize that patient's participation. And then all the way on the right, you'll see a walking sling. And this can be used with either a mobile lift or a ceiling lift. And this really helps protect a patient from fall and let them independently walk. You bring the lift up just as seen in the picture where there's tension, but it's not actually lifting the patient. The patient has to do the walking and the movement on their own. It's great for training a patient to use a crutch or a cane or a walker. It's really great for therapy when they're doing balance activities, bouncing that ball, and the patient may lose their footing. And it's also great for any ambulation that a nurse or a therapist might perform where they're just not sure if the patient is steady enough to remain standing. Then there's the other categories. There are so many other things in healthcare that we have to perform that you have risks that you see. And we have options for limb holding. We talked about it in labor and delivery and in wound care. We also know that sometimes patients will show up to the hospital or the emergency room in a car, and they may not be able to get out of that car. Excuse me. So we want to be able to help them out of that car safely. And then patients, unfortunately, even though we've done everything to prevent their fall, they do fall sometimes. And recovering a patient from the floor is one of the most dangerous activities if we're doing it manually. So we want to look at the fact that there are so many other options. And really what I would recommend is if you are having injuries occur or you have staff that are reporting, we have a lot of difficulty with, and they give you a random task that you might not be aware of a solution, please reach out. And I'm sure that if you're having a problem, somebody else has. And there are so many devices out there that are made to really help prevent all of those injuries. So when we look at solutions for efficiency, let's just look at some of the basic tasks. Bed to bed transfers, bed to chair transfers, ambulation or walking, wound care, or boosting up in bed. This is a chart that just really helps you understand how much efficiency you're going to see with the different types of equipment. When you use a ceiling lift, all of these transfers or activities only require one person. So you're getting the most efficient care. So that's why we tend to see, like in the FAMA guidelines, that the ceiling lift is recommended for the ICU, 100% for the ICU. It's not recommended 100% anywhere else. And the reason is that that is the most dependent patient, and they tend to have one-on-one care. So it really makes the most sense to invest in this technology in an area that we know has a high tendency to perform all of these tasks independently. And then we look at the mobile lift, and the mobile lift can help cover multiple rooms, but for bed to bed and bed to chair, it does require two people. You need somebody to be with the patient and somebody to move the lift. For ambulation, only one person. Wound care and boosting in bed, only one person with this mobile lift. So that still offers a great amount of efficiency. Bed to bed, bed to chair, and ambulation on the mechanical sit to stand can be performed with just one person. So that also, depending on what kind of task you're looking to do, might be the best choice. But when you look at, depending on your super strong nurse, it might take 4, 3, 2 people to perform these tasks if you're doing them manually. And that's actually below the recommended limit based on this patient's weight. So really start thinking about that and thinking about how do we look at safety and efficiency together when we're choosing our equipment. When we look at falls prevention, this brings back some of the equipment that I already talked about to consider. When we are walking a patient who might be unstable, bringing them from one department to another, from one room to another, or just simply into the bathroom, using one of these devices helps prevent them from falling. We can promote their independence with these devices, but we can still ensure that we're not going to have the patient fall. And this really does take the proper assessment to determine which piece of equipment makes sense for these patients. And then when you look at pressure ulcer prevention, we know that we have to turn the patient frequently and that we want to reduce the friction when we're moving the patient around. So the devices that you're going to look at for pressure ulcer prevention are those that assist with turning and those devices that have friction reducing qualities. So you have your friction reducing slide sheets. On the top picture, you see a picture of sheets that have it's like a satin material almost on the inside, and they face each other, and it really helps you to move a patient around. We use these a lot in the hospice and home care setting. They're very comfortable, but it helps you to easily be able to move your patient without that shear and friction occurring. And then in the bottom, you see the ceiling lift, and then again, that safe handling sheet assisting with turning. And you can really perform this independently. If there were not 2 caregivers, you would give the one caregiver would bring the side rail up on one side, should be able to turn the patient, put the pillows in, let the patient down, and not be waiting for other caregivers to assist. And what we find is that often those Q2-hour turns that are assigned, they don't often happen every 2 hours, and the number one reason they don't happen as prescribed is due to the lack of people available. So if you're not depending on people to help with this task, you're likely to get it done for sure. I'm going to go quickly through these next two since we're running low on time, but you want to make sure that there's been not only a pressure mapping study on the safe handling sheet that you choose, but also a breathability study. And really what this shows is that this sheet is safe for your patient to lay on, even on a low air loss mattress, even with fragile skin conditions. So I would ask your vendor for a copy of this for your wound nurse if you have any resistance in that area. Just like we talked about before, for early mobility, if you have an early mobility protocol, we can assign equipment that helps match each of those levels of protocol. So typically they start with something like in-bed activities, and then you move to out-of-bed activities, and then you move to ambulation. And there are so many different options that you can perform these activities to best optimize those patients' outcome without risking the staff's injury. One of the most important things you can do to get started are to look at your data. And that data really helps you understand what is the total impact to my organization and what does that mean for me to be able to help push this forward and implement safe patient handling. I always recommend an injury follow-up. Anytime you have an injury in your organization, to do an interview. And I have a root cause analysis tool. It's here on the screen. I'm happy to share it if anybody wants it. And it really helps you understand, why are these injuries occurring? And what you'll often find is that your staff say there was no equipment available, the equipment didn't work, or I didn't know how to use it. And those are things that are easy to fix if you know what the problem is. A survey is a great way to find out what's going on your floor, in your hospital, or in your unit, or long-term care facility, and to design a survey that asks why the staff are performing the tasks without equipment, what would make them use the equipment, and what they feel the barriers are. Really, an analysis of your injury data, like we talked about, is a great way to understand where are the risks in my organization. And then finally, a facility assessment. And your vendors are more than willing to do that. And I know that's something Lifeway Mobility is willing to help with, is do an assessment and help you understand what are my risks and what can I do to really decrease some of these costs in my organization. So now I'm going to open it up if anyone has any questions or wrote me questions on the panel. I'm not seeing any that were written. So I can unmute. So if anyone has any questions, you can ask them now. Otherwise, you can go to lifewaymobility.com or email info@lifewaymobility.com or call the phone number listed on the screen, and you can ask questions or ask for a copy of the presentation, and we'd be happy to help you. Also, this presentation will be posted on lifewaymobility.com if you wanted to refer to anybody else or watch it again.
Amber.
Yes.
I'd like to ask a question about why is a ceiling lift just a one caregiver's necessary versus a floor lift that's two?
Now, that determination really ultimately is up to the facility. But with a mobile lift, you have the patient dangling from the lift, and then you have the lift that needs to be moved. So you have one caregiver that tends to push the mobile lift and one that will stay with the patient and kind of guide them from surface to surface so they're not swinging like a pendulum. The ceiling lift, as you move the patient, the lift moves. So the person who's moving the patient is also moving the lift, and they really just glide. There's no force needed to push or move that patient. So the safety in the two people is that you want somebody to stabilize that patient with the mobile lift. But that's really only recommended for out-of-bed transfers. However, if your organization says it's perfectly safe to use one lift to do those things, that's fine. That's really up to the organization, not up to the vendor.
Okay, thank you.
You're welcome. And I think that's it. So I just want to thank you for participating. And again, visit lifewaymobility.com or info@lifewaymobility.com for any questions.